Okay, so I've just been asked to give a bit of a summary about joint preservation. Uh, and so, yeah, we'll try and cover as much as we can in the 45 minutes. So what is, yeah, so what I was just writing a grant the other day and saw some of these figures and I thought they were quite interesting just to look at the scale of the problem. So this is from Versus Arthritis State of the Nation, a report from this year. So 21% of people live, or 21% have years lived of disability down to musculoskeletal conditions. So it's a huge cause of morbidity. It's estimated 5.4 million people in the UK currently have knee osteoarthritis, which is the majority really of the 10 million people thought to have OA. If you have sort of knee or low limb in particular, or back OA and conditions, then it has an amazing impact on your general well-being in that you're 3 times more likely to have cardiovascular disease, you're 61% more likely to have diabetes, you're 2.5 times more likely to have multiple comorbidities, and around 20% of people with OA suffer with depression. And the cost of this is over 100 billion annually in terms of work loss and sickness absence from the UK. So it's a huge problem, and yeah, we need to get better at treating that. Before we start, though, I want to just caution people. Really, one thing that really well, it does annoy me a bit, but I think we have to be very careful about is our language. So essentially on the left, that's a picture of a cartilage lesion. So that's cartilage disease. And yes, over time and with progression, we can progress onto osteoarthritis. But these are two different entities. They're on the same scale of cartilage disease, but they're at opposite ends of the scale, and one does not equate to the other. And you might not think that's an important distinction, but in terms of qualification for individuals for certain treatment, it has a huge impact. If you describe someone as having osteoarthritis, where they have cartilage disease, an isolated cartilage lesion, you're dependent on who's funding, and that includes the NHS. You can exclude them from certain treatments. So it's really important that we use our language carefully. So joint preservation strategies. So this is a spectrum, and this is the sort of thing that you can see for the treatment of knee cartilage disease from start to finish, really. So you going through repair, then regenerative procedures. Then we've got sort of offloading procedures such as osteotomy, and then we've got arthroplasty, and then revision arthroplasty, and then the salvage stuff at the end in terms of arthrodesis and amputation. So we're really trying to work on this green box, really, in terms of joint preservation. And that's a combination of strategies. That's osteotomy, cartilage repair, meniscus transplant, and ligament reconstruction. And they can occur in various combinations, and in any number. It can be isolated, could be all four. So, but they're the main sort of four strategies that we're trying to work with. So cartilage repair, so we'll cover that first. So symptoms include pain, catching, clicking, instability, and effusions. The important thing is about the knee is to think about it as an organ. So it's not just about the cartilage repair. The cartilage repair bit is the last thing that we do. Okay, before you can even contemplate a cartilage repair, you must satisfy other three criteria. So the knee joint must be mechanically aligned. It must be straight. You cannot do a cartilage repair in a compartment which is being excessively loaded. It must be a stable joint. Sorry. It must be a stable joint. So you can't have any ligamentous instability. It must be it must have a functional meniscus as well. You cannot do a cartilage repair if you've got more than 50% of meniscus loss. So you have to think about the knee as an organ, and you have to have all those elements in place before you can then correct the cartilage. And this is the sort of situation we're trying to avoid. Uh, a second, for some reason it's not moving now. This is a situation we're trying to avoid. So this is a 21-year-old girl who's actually a daughter of a GP. She had an ACL rupture when she was 14 years of age. This was treated conservatively, and then she's come to see me at 21 years of age. She's got full thickness cartilage lesion on the femur. She's completely trashed. She's got a second lesion there. We'll have a look now at the meniscus. Because of her recurrent instability, she's completely trashed that meniscus. So that meniscus is not really functional. She's got a cartilage lesion on the tibia. She's now in varus alignment, where she was in a little bit of constitutional varus alignment, but that has progressed. And you can see that's where the ACL should be. There's no ACL. So all these things are linked, and there's a degree of snowball effect. So instability leads to a meniscus damage in combination with her constitutional alignment has then led to medial compartment degeneration. And that's how important these structures are. And we have to address them all and not just focus on one element. So in terms of cartilage repair strategies, in terms of small lesions to begin with, we can still use microfracture, but really should be still looked at really small lesions. It's been previously used for all comers, and half that problem is because it's cheap. There is no implants. You can just get these little awls off the shelf, and then you poke some holes in the bone to let the marrow come out, and then it forms a fibrocartilage over the top. The problem is with this, it doesn't require any planning, and then people can be very tempted. They see a cartilage lesion, they treat the cartilage lesion, but they've not assessed the alignment previously, and that's the biggest mistake, and therefore the cartilage repair can fail. But microfracture has been around for many years. It has a long history of clinical use. It's safe. It can be effective in small lesions. But the problem is that the larger lesions, the fibrocartilage that forms breaks down over time, and there's increase in failures after 5 years. And the problem is as well with microfracture is by poking those holes in the bone, you change the biomechanical properties of that bone, and as a result, then it's recognised that any future cartilage repair has a worse outcome as a consequence, because that bone is much stiffer. It loads the new cartilage repair much more, and therefore it fails and breaks down. So you have to be careful when to use microfracture for the right patient, right indication. The other sort of traditional treatment would be an osteochondral autograft. So this is where you take a dowel of cartilage and bone from a more non-weight bearing area, such as the trochlea. You drill out your defect to match. So you drill out the defect. You take a matching dowel from this non-weight bearing area, and then you insert it into the defect. The bone that you took out of here, you put into the donor site. And this is a single stage procedure. It's relatively cheap. It's the only procedure that involves you end up with absolutely 100% normal hyaline cartilage in the defect. This cartilage, though, never joins to that surrounding area, so you get fibrocartilage there. It's bone-to-bone healing, so you get a more rapid recovery. But the problem is with this is that you're limited by the size of the lesion. So for me, so some people go up to 2 centimeters. For me, it's just 1 centimeter. I don't really want to be taking more than 2 10 mil dowels really from the patellofemoral joint, because you're robbing Peter to pay Paul to a degree, and the worry is about the morbidity you cause in the patellofemoral joint. to treat your femoral condyle. So you could end up a situation where you just swap one pane for another. So this is really limited to less than 2 centimeters. So then if we get into the bigger lesions, so then we're moving on to more sort of expensive treatments. So autologous chondrocyte implantation. So this is a two-stage procedure where you take a biopsy from the cartilage, such as this up here. You send that off to the to a laboratory, and then they take out the cartilage cells. You grow the cartilage cells then in the laboratory, and then you re-implant them around about 5 or 6 weeks later. And this would be done under a patch in sort of more traditional generation. But we'll see a bit later on. But the more newer generations, these can be done as sort of injectables. And this can, so therefore it can be an open operation. It can be an arthroscopic operation. And at the second stage, again, we're treating any associated abnormalities, so alignment, stability, meniscus. So the bottom here is the injectable. And so each one of those little yellow balls has 200,000 cartilage cells within it. And this is a similar sort of thing. So this is a lesion we treated in the patella. So this is a time of implantation with those little yellow balls, and this is it a year later. And this is a sort of regenerate that you get. You can see the color difference. So it's not normal cartilage. It's not fiber cartilage. We call it hyaline light cartilage. So it's a halfway house between normal cartilage and scar tissue, essentially. This is NICE approved. So we can do this in individuals with a cartilage a lesion greater than 2 centimeters. They have no previous history of cartilage repairs. We cannot do this if you had a previous microfracture because of those failure rates. So that's why it's important to get it right first time. No osteoarthritis. So this, again, this is important about the language we use. Similarly, if you have a osteophyte, that is not osteoarthritis. It's one of the markers, but it can also be a reflection of the chemical environment. It does not mean you have osteoarthritis. And then it must be done at a tertiary referral centre. And it's estimated that around about 500 people per year in the UK should be having ACI. In Germany, it's more like 2,000, so 500 is probably a bit conservative. But at the minute, we're poorly performing because we're actually only managing around about sort of 50 to 60 a year, and we should be treating many more patients with this technology. So then we've got osteochondral allografts. So this is the other strategy that we can use. So this is a bit similar to the autologous version. So where we can take a dowel just like this, and then we can implant it. But the thing is with this is that actually we can actually take half a condyle if we want, because this is donated bone. So when they give you when you get an allograft, they actually give you a hemicondyle. So they give you half a femur essentially, and you can take as much or as little as you want from that. So you can take a dowel, or this is what we call a shell allograft, where we've replaced half the condyle here. So the advantage of this, bone fixation again, just like the autologous version, hyaline cartilage again. But the main advantage is, unlike the autologous version, it's not size limiting. The difficulties with this technique is limited supply and costs. We have to get this from the United States. An allograft costs around about £16,000. We are limited in how many we can get. And the other thing is that from the day that this is donated, the cells decrease in viability, and we want these to be as viable grafts as possible. So you have a 28-day window to implant these grafts. Because you've got to check that they don't have any diseases such as HIV, Hep B, Hep C, you've got to wait 14 days before the company releases those grafts. So in reality, you have about a 10 to 14-day window to get the patient in, implant the graft. We've noticed, though, from our graphs coming from the States, that the viability isn't as good as it should be or is as reported. So we're not quite sure what the implications are going to be for that in terms of our results, and it's something that we're currently investigating. The worry is that you take a really big piece of bone like this and you've implanted, is what happens if it doesn't heal on. You're left with a pretty large defect, and it's a difficult salvage situation. So it's not to be taken lightly, but thankfully the risks of non-union are pretty low. So I wrote a national policy on this last year, 2 years ago now. And essentially it follows a similar sort of guidelines to what we did for the ACI. So again, it's for lesions greater than 2 centimeters. You must not be suitable for ACI. So ACI should be the primary method, because essentially we can only get about 50 grafts a year. So we really need to keep these grafts for the people that really, really need it. We can use this in revision procedures. So if you fail a microfracture, we can do this. Again, no OA, and again, it should be performed in a specialist cartilage centre, of which there's currently 7 in the UK, but there should be, hopefully by next year, around about 13. So, and they're spread throughout the country. This is the sort of extreme case where we would use this instead of an ACI. So this is a 21-year-old patient. She's had chemotherapy, survived her leukemia, but unfortunately has been left with this knee. This is what it looks like. You can see cartilage is just peeling away, the bone's all dead, and yeah, they're in quite a lot of pain and difficulty at the age of 21. So yeah, so you can take this as the sort of hemicondyle, so half the knee. We've cored out the areas that we wanted to replace. We've created these dowels using a specialist kit, and then we can implant them into there to give her a new surface. And this is how they look then. 18 months later, we get this good integration. Cartilage looks good. It's a good match for her condyle. And yeah, and that's a simple option. This is like the severe option, where basically half the condyle falls off. And then you end up with these big shell allografts that we have to put on here. You can see it on the X-ray here. We've removed that. We've hand-shaped that to fit the defect. And then we've had to do an osteotomy at the same time to offload that area. And it should be pretty rare that you ever do a cartilage repair without some sort of osteotomy, ligament reconstruction, meniscus transplant maybe. And when we've looked at our series, it's only 7% of people that should really just have an isolated cartilage repair. And you can get some good results. So these are results for osteochondral allografts. So even at 15, 20 years, you can get 65, 66% of people at 20 years that don't need anything, 74% at 15 years. But obviously these are the sort of milder end. The last patient I just showed you, their failure rate will be much higher. And similarly, ACI, you can do 71% 15 years. We've just published a paper to show that you can avoid knee replacement following ACI in 82% of cases at 20 years. So you can get some good longevity in these patients, but you really need to adhere to those rules as well about the associated problems. And the main associated problem is osteotomy, or is malalignment, so osteotomy. And this is recognized as the biggest cause of all cartilage repair failures. So essentially, what we're looking to do is offload areas of damage. That's either in the situation of a cartilage repair, where we're trying to offload that repair, or in the situation of arthritis. So they've got unicompartmental arthritis, and we're trying to offload that to provide some pain relief and functional benefits. The threshold for osteotomy or realignment surgery is much lower than that of joint replacement, and it can significantly delay the need for joint replacement. But the thing is with osteotomy is that there is a point at which you cannot do the surgery, and that's principally because, say in this situation here where we have varus alignment, So we're excessively loading the medial compartment. If we are going to offload that medial compartment and restore them to neutral or slightly valgus, then that lateral compartment needs to be intact. The kneecap joint needs to be intact. There's no point loading them onto a bad surface. Otherwise, you're just swapping one pain for another. So that's why there is a point at which there is you cannot do this surgery. So there is no we don't wait until like knee replacement until you are absolutely struggling that you cannot tolerate or your function so low, because there is no point at which knee replacement cannot be done. There is with joint preservation surgery. And there's some interesting facts. So Liam Williams here, so he's probably the most bow-legged man in the world that functions really well. But essentially, if you have more than 3 degrees of deformity, so in this sort of situation, if you're more than 3 degrees bow-legged, then you have a significantly increased risk of osteoarthritis. And if you have 4 degrees of deformity, then if you say develop a meniscus tear, say like that girl we saw at the beginning, and then she went on to cartilage damage. But if you have more than 4 degrees of deformity, the progression or the natural history of that deterioration will be 10 to 20 times faster. And so your alignment is key to how quickly you will deteriorate and what your prognosis will be. And this is sort of serious. So this kid's got medial compartment arthritis. Here's the long leg alignment films that we use. We draw a line from the center of the hip to the center ankle. This shows us where they're loading. So they're loading the medial compartment. There we can get SPECT CT scans. They can show osteoblast activity. So you've got significant increased activity within the medial compartment. You can then do your osteotomy to offload or that. You can repeat your SPECT CT and you can see we can significantly reduce that load without excessively loading the normal opposite side. And then they are generally going to be associated with a very good result. So this would be another more severe example. So this guy, 38 years of age, significant varus alignment. So the mechanical axis isn't even in the knee joint. He's now able to do no sports, struggling with activities of daily living. He can go on to have a double level osteotomy. So his varus was so bad that he had to straighten the femur and tibia. And now, a year after, they can get back to impact activities. In this situation, you can, because he's not got severe arthritis. His joint was just struggling. His meniscus was degenerating, but he didn't have any frank arthritis. So we don't mind them getting back to impact. If this was for arthritis, he had established arthritis, then it's probably best to avoid impact. But it's a very, very powerful operation. So then meniscus transplantation. So this is implantation of a donated meniscus allograft. Meniscus is size matched to the patient. No need for tissue typing. So it's aimed for people with pain within a compartment of which they have lost their meniscus following meniscectomy or a failed repair. It's for symptomatic cartilage lesions in association with cartilage repair. So if you've got like that girl at the beginning, so she's got really bad cartilage, you need to do cartilage repair, but she's got less than 50% of cartilage of meniscus remaining, then you need to do a meniscus transplant, and also in association with ligament reconstruction. So if you are doing an ACL revision, for example, generally, and you have absolutely no meniscus, either medial or lateral, so this would be in combination, because the stability and the outcome of that operation would be better with the meniscus, as it's a secondary restraint. The medial meniscus restrains AP motion, so it restrains your Lachman, and the lateral meniscus is more helpful for rotational, so that helps you control your pivot. So this would be examples. So this is my patient, actually. So I did an ACL meniscus repair. She's a paramedic. the meniscus repair failed. She continued to get medial compartment pain. Her alignment was normal, so we couldn't do an osteotomy to offload it. So she had to go in for a transplant. So you debride the meniscus rim, you get it back to the native rim, and then you can shuttle in this meniscus here, and then you suture it all around. And you also drill some bone tunnels into the meniscus roots there to secure it to the bone, and that's sort of what it looks like. And then this is her. So we did that operation in 2011. And this is what it looks like. So it never looks like a normal meniscus. So this is her over a 10-year period now. She's still functioning well with no pain. The reason we've got the scans is because her patellofemoral joint is deteriorated slightly, but her medial compartment is doing well. You can see that does not look at a normal meniscus, but it's clearly still functioning because her pain's gone, and we're not losing any cartilage thickness. So her cartilage volume has stayed the same over the last 10 years, 11 years. So the meniscus is doing its job to protect that cartilage surface. And this is just really to prove the point that it's pretty rare, like I said previously, that you do these procedures in isolation. So this is, for example, one case. So it had a large tibial defect. So with modern day ACI, we can go in, we can treat that cartilage lesion, we can inject these spheroids. Here come the little yellow balls again. We can inject that, we can distribute that. This patient also required a meniscus transplant, but also he was in varus, and as a result required an osteotomy in addition to his transplant and ACI. So you can see how it's not the cartilage procedure that sort of adds really to the complexity. That's probably the easiest bit. It's the additional procedures and the combination of additional procedures that really ramps up the complexity in these patients, and how long these operations can take. So it's important, though, to assess and address these factors, because if you just did the cartilage repair without addressing the alignment, without addressing the meniscus, there's just no way that this will heal. And then what to do when all has failed. So we tried all out joint preservation, and this is the sort of real salvage operation that we do. Thankfully, we don't have to do it that often, but we can do joint distraction. So essentially, in individuals that say may well truly have a tri-compartment disease, you can, and there's no role for osteotomy, no role for cartilage repair, no role for transplant, then distraction can be a bit of a salvage type situation where we can try and basically try and prevent the or try and delay the need for joint replacement. So you put an external fixator on above and below the knee joint. You then can distract, so you pull the knee joint apart by 5 millimeters. You leave that in place then for 6 weeks, and then you remove the external fixator. You do an MUA at the time of that in theatre, and then they can start to weight bear as normal. And the idea is that if you distract the joint, you take all the stresses off, and this gives the joint time to heal or time to try and regenerate. And there are some good quality randomized controlled trials, mainly out of Holland, where the technique's really been pioneered and pushed, showing that over a relatively midterm outcome, so around about 4 to 5 years, you can achieve comparative results to osteotomy and total knee replacement with joint distraction. So we'll do maybe 1 or 2 of these a year, but they're certainly doing many more than that in Holland. But it's just that last chance to try and delay joint replacement in these younger patients. Okay, so I just thought I would just go over for 5 to 10 minutes, just go over the conservative management of OA. So we've got to the point our joint distraction has not worked, and you're really waiting for their joint replacement. And I thought I'd just go over some of the current guidelines quickly. And that's basically because you're trying to delay joint replacement. And this is because there's still it's not a perfect solution, joint replacement, and 20% of individuals will still not be that happy with it. That satisfaction rate is worse in people under 40. Also, the revision rate is worse in people under 50, and people just don't like it for various reasons, in the sense that they can have semantic knee pain, they can't kneel, they don't like the clicking, clunking, they can't run or do their usual activities. So if you look at, so there's three big high-powered reviews and consensus statements that generally we can use. And these are from NICE, the ORSI, which is the Osteoarthritis Research Society, and the American Academy of Rheumatologists. And I've just picked out a few aspects of the reviews just to highlight a few aspects of the management. So NICE, interestingly, have said that you can diagnose osteoarthritis clinically without investigation if a person is 45 and over and has activity-related joint pain and has no morning joint-related stiffness or morning stiffness that lasts no longer than 30 minutes. Now, I picked this out because, yes, you probably can, but I don't think you should be condemning this group to conservative treatment infinitum until they fail, so that you can go and have their joint replacement, because this is the population that is open to osteotomy. So I would still advocate that, yes, you don't need the X-ray to diagnose OA, but I think if you do get an X-ray after some initial simple treatments, so 6 weeks to 3 months, and they continue to have pain, then I think that's the point when you certainly are open to investigation, because they may be amenable to joint preservation. You don't need to wait until they're on their last legs, basically, before you consider a realignment. And actually, that it's often a bit too late at that point. So so I just wanted to highlight that aspect. But essentially, these reviews. So this is NICE reviews. So essentially, they all involve roughly the same thing. So the principles of treatment are exercise, weight management, and self-management, so information. So knowledge is king in this sort of scenario. So it's pretty disappointing that this is all that they've sort of come up with to a certain degree. But these are the strategies that have been shown to be effective, or have the most research behind them to show that they are effective. Particularly the weight management in today's society. So even as by losing 5% of body weight has been shown to have a meaningful, clinically important difference in outcome scores. And obviously, the more you lose, the better that goes. So not much weight loss can have probably one of the most effective improvements in individuals in terms of the various tools we have for conservative management. I think it's important to signpost people to the various appropriate agencies for their knowledge and education. I'll come on to that in a minute. But and then I think what's more interesting about these guidelines is what they don't recommend rather than what they do recommend. So they don't recommend manual therapy, and they do recommend some walking aids, but they don't recommend acupuncture, dry needling, electrotherapy, insoles, braces, tape, splints, or supports routinely. And then when you come on to pharmacological agents, it's topical anti-inflammatories as the first line. Consider oral if the topical ones do not work, but obviously you have to be mindful of their cardiovascular status and their GI status. And then do not offer paracetamol or weak opioids unless they cannot take the anti-inflammatories, because they have not been shown to be effective in OA, do not offer glucosamine, strong opioids, and they say do not offer intra-articular hyaluronic acid, but we'll see some disagree with that. And the only injection that they do recommend is intra-articular corticosteroid. So ORSI, the Osteoarthritis Research International Society International. So again, exercise, weight loss, and education to promote hope, optimism, and positive attitude. And then they rated the various evidence for the various interventions. So aquatic exercise, gait aids, cognitive behavioral therapy. They've recommend those and include patients with comorbidities, depression. So these, particularly the ones with mental health issues, the CBT sort of therapies are effective. These are the agencies that are probably the most useful in terms of the education. This one versus arthritis is, I think, in my view, probably the best. And they have a very big patient-facing website. Even goes through their Let's Move with Leon, so that they show you the exercises that you can do. And I usually signpost people to this one. But again, topical NSAIDs are recommended. Oral NSAIDs, as long as you've got GI cover, but not if you've got cardiovascular morbidities. Or she recommend steroids, and they recommend HA. And then in terms of supplements, so glucosamine and are no longer recommended, and these are the ones that are currently recommended: avocado, soybean, and saponifibrables, boswellia, so Indian frankincense, and curcumin, which is the active ingredient of turmeric. So like I said, just not recommended paracetamol, oral or transdermal opioids, topical caspacin, chondroitin, vitamin D, laser therapy, acupuncture, electroacupuncture, electromagnetic therapies, TENS, therapeutic ultrasound, nerve block therapy, currently is not recommended, although I would say that this is becoming much more popular. But I think the evidence for this at present is still not as strong. And again, not recommended. Modified footwear wedges. You see regularly people going off and spending lots of money on various people's recommendations for insoles, but you're probably better off just buying a pair of running trainers. And there are some, I'm just going to finish, but there are some RCTs so that have looked at the various supplements. So avocado and soybean, whether you do 300 or 600 milligrams has been shown to improve. And then curcumin, again, it's 15 milligrams 1,500 milligrams per day in 3 divided doses was the dose that showed. So it's quite high doses that you need to take, and that was in a placebo-controlled trial. So, and this is the American Academy of Rheumatology. So, and it's all pretty much, it follows the same. So these are the things that they sort of do recommend, which are pretty much in sync with the others. So a lot of the core sort of core training exercises in terms of yoga, tai chi, and then weight loss exercise, topical and topical orals. The light green acetaminophen or paracetamol only if you're not suitable for the non-steroidals, and duloxetine in people with mental health or depression, anxiety are shown to be effective. And again, these are the ones that they don't recommend: dark red strongly, light red less strongly. But if you look through the list, a lot of these things are sort of pretty commonly in use. But the evidence for them is pretty poor. But a lot of the time they're being used because there's no safety concerns. But even common things like fish oils and vitamin D, though, are still not recommended because the evidence is really very weak, and including PRP at the present as well. And then I just got to finish on bracing. So a lot of them were saying about bracing. I think generally when they go to that, it means about your typical sort of soft braces. But I think there is pretty good evidence to demonstrate in RCTs that offloader braces can be effective. They're not suitable for everyone. Females don't like them as many as males. Some of that is to do with the cosmetics. Some of that is to do with the leg shape. But there are individuals that can really benefit from offloader braces, but they are expensive. But I think they are a useful adjunct in the sort of conservative treatment of OA. So I'll just finish there. Thanks.
Thank you, Professor Snow. That was brilliant. We have got a couple of questions if you're happy to stay on and I'll
Yeah.
answer them. There was a question before about the 21-year-old. What happened to the 21-year-old? I think you have covered it, but still, if you want to maybe summarize.
Yeah, so we did a cartilage repair, ACL reconstruction, and I think she had a meniscus transplant as well at the same time. And yeah, I haven't seen her for about 6, 7 years, so I'm taking that as a good sign.
Thank you. Um, is there any evidence for use of gabapentinoids for managing pain in osteoarthritis?
Um, no, um, essentially, I think it's not. No one's done there's not sort of high level evidence. I think it's almost like the salvage equivalent in the pain world that certainly our pain team want you to have had a trial of pregabalin before they see them. So it's almost become part of management in those people that are really difficult to treat. But and when I say that though, I'm specifically really talking about knee arthritis and not about spinal issues.
Brilliant, thank you. I had a question about arthrosamid. I think lots of patients come back to you and ask because
Yeah.
that's offered in the private sector. What's your view on that?
Yeah, so I've just finished. So we've done a trial using arthrosamid. So essentially, we haven't published it yet, but because we're still waiting for some data. So we were doing a study to look at the mechanism of action because it's still not 100% clear. Essentially, we injected 65 people. We took off synovial fluid, and then we took some more synovial fluid off 3 months post-injection, and we're analysing that fluid really to look at the mechanism. But obviously, we looked at the clinical outcome. So basically, what I can say is that our data is now up to 12 months, and the data does seem to reflect the company's data, which I suppose is reassuring. The response rate will be around about 75, 76%. You will get in those individuals, the mean increase in the WOMAC score was 21, which is well above the minimally clinically important difference of 10. I think in terms of people that are better suited to it, it would appear that the younger patients, potentially under 65, do better. But as of, it's difficult to predict, but obviously, it's pretty expensive. And so, it's one of them. You got a 1 in 4 chance of it not working, essentially.
And as opposed to the visco supplementation, would you prefer arthrosamid for patients who are younger than 65?
I think we don't know. I think that in reality with osteoarthritis there are probably 4 or 5 different subtypes. So and essentially there are probably individuals that suit the different phenotypes of OA probably are suited to the different injections. It's just at the minute we don't have a way of linking those people or really studying those people. And I think that's half the problem why we see this variability in the HA literature. Some showing great benefits, some showing not. It just probably depends on what proportion of the subtype that the subtypes that you've included in your study. So from for me, I generally recommend that people maybe try it's definitely try a steroid because it's generally free.
Mm.
And then if they, you could at least have had one of the other injections. The HAs can be expensive, so that's not, it's not a cheap one either necessarily, but it's a lot cheaper than the sort of like £2,500 that you're looking at for an
That's just,
arthrotamid injection. But I think it is very promising. I think it is, and we're continuing to follow our data because the company obviously showed benefits out to 3 years and 4 years. So we're
wow.
out to 12 months, and yeah, people still seem to be doing very well. So I think it is very, very interesting.
Thank you. There is a question from one of the GP who specialize with specialized interest about they're based in Yorkshire and they're asking about would you accept GP referrals from their area if we are stuck with conservative management or away?
Yeah, no, well, yeah. So we see people from all over the country. So at the Royal Orthopaedic. So yeah, no, I not infrequently treat people from Yorkshire. Usually
Brilliant.
they've come from another consultant. So, but yeah, it's not unusual.
Brilliant. Thank you. That I think that answers the last question as well. Thank you so much for
No
coming in.
worries.